presenter mode yet. Perfect. That works.
Better?
Yeah. Okay, great. So we'll get started. It's my pleasure to introduce our next speaker, Dr. Aparajita Singh. Dr. Singh is our director of UCSF's GI Cancer Prevention Program with a focus on patients with family histories of GI cancers, Lynch syndrome, as well as FAP. She completed her medical degree in New Delhi, residency in internal medicine at the Cleveland Clinic, fellowship here at UCSF, as well as an MPH from Johns Hopkins before joining faculty here at UCSF. She is part of several different national collaborative groups for inherited gastrointestinal cancers and is on multiple professionalism and training committees as well with our national GI societies. Dr. Singh wears many hats, and in addition to her clinical duties, also serves as the director of our quality improvement for the GI division and runs our department's M&Ms, as well as oversees a lot of our QI departmental projects. And Dr. Singh is also very passionate about working with our trainees, including medical students, which I was one of back in the day, as well as residents and fellows. And outside of work, Dr. Singh spends a lot of time with her family, her husband, and her 2 energetic sons who play soccer. So today we are very lucky to have Dr. Singh share her expertise with us with her talk titled GI Polyposis Syndromes.
Thank you so much, Lakshmi, for this lovely introduction. Makes me happy to see you from having you as a SPAN medical student with me and as fortunate to have you as my fellow. So let's get started. I have a lot of slides, unlike the short talk you had. So let's get ready. Okay, so I have no relevant disclosures for today's talk. So we will talk today about colonic polyposis syndromes, but let's talk about genetic risk for colorectal cancer. So what happens if we do genetic testing for all the patients who have colorectal cancer? This is a nice study from Elena Stoffel's group. And here you can see that if you take a look at all the patients who are under 35 who have colorectal cancer, 65% of those, the genetic multi-gene panel testing will be negative. In about 23% of these, you will find Lynch syndrome, and roughly 9% of these younger individuals will have polyposis syndromes. And then if you look at patients, all the patients aged less than 50, the number of Lynches is about 10%. Polyposis syndrome, the focus for today's talk, is about 3%. And again, about 80% of these patients aged less than 50, they have negative multi-gene panel testing. If you look at older patients, so age 50 and above, Lynch syndrome makes about 3% of those colorectal cancers. Polyposis syndromes are still less than 1%. And what genes do we find in genetic testing for these colorectal cancer patients? So Lynch syndrome genes, which is a different talk in itself, and the polyposis syndrome genes, the ones we will talk about today. And in these individuals, you can find other genes, and the list here is high penetrance genes, which is BRCA1, 2, TP53, PALB2, CDKN2A, and the last column here is moderate to low penetrance genes. So in these colorectal patients, we do find some of these genes which are not necessarily, high risk for colorectal cancer. For example, CHEK2 or ATM. So those are also the findings. Okay, so now coming to the main topic today, which is GI polyposis syndromes. So when I see a patient with GI polyposis syndrome, I try to put them in 3 buckets. Whether it's adenomatous polyposis syndrome or serrated polyposis, or the third bucket is Hamartomatous. We will look at this slide multiple times today. So in adenomas, we have the common ones. The 2 most common ones are FAP and MAP, which is MUTYH associated polyposis. The rare adenomatous polyposis syndromes are POLS, NTHL1, MSH3, MLH3, AXIN2, GREM1. These are lots of newer genes that we are finding, and every couple of years we see this list growing, and we have added actually a few more since I made these slides. And the rare adenoma-causing syndromes are Lynch CMMRD, which is constitutional mismatch repair deficiency syndrome, therapy-associated polyposis, and colonic polyposis of unknown etiology. The second bucket is serrated polyposis syndrome, and in Hamartomatous, we have juvenile polyposis syndrome, Peutz-Jeghers syndrome, and the last one, which is the rarest one, is PTEN hamartoma tumor syndrome. So let's talk about a case example. I have some cases from my clinic. So this is a 23-year-old woman. She has no past medical history, and she goes for her routine eye exam. So she is noted to have multiple retinal spots. You can see a sample image here. So she has many of these bilaterally. She has no family history of any polyposis or cancers. And this patient is referred to see a GI by her eye doctor. What do you think? Any guesses? What is this? Okay, so these are chirpies, and this is a real case example, and she turned out to have FAP. So, second case example, a 30-year-old woman with a history of breast cancer. So she undergoes multi-gene panel testing, and her testing shows a mutation in APC gene, and this particular mutation is I1307K, known as 3920T2A. So this patient is referred to you with APC gene mutation. The question for you is this FAP? Should you do colonoscopy, send them for surgery? I can't see the chat box, but feel free to share your thoughts.
I can moderate the chat for you, Dr. Singh.
Okay. Okay, so we'll discuss this. This is not FAP, even though this particular APC gene mutation is a common mutation in patients with Ashkenazi Jewish descent, and occasionally we get referrals for these genetic changes as well. So let's talk about FAP. So FAP, familial adenomatous polyposis, is due to mutation. So we use the term mutation, but it's actually, I will be using the other term as pathogenic variant, which is a more favorable term lately. So it's due to a pathogenic variant in APC gene, which is a tumor suppressor gene on 5q21.22. It's an autosomal dominant condition, and there is nearly complete penetrance of colonic polyposis. And the extra-colonic manifestation, there is variable penetrance, meaning some of these patients will get extra-colonic manifestations, others will not. And the estimated live birth incidence is about 1 in 8,000 to 1 in 10,000. Important to notice that nearly 25% of FAP is due to de novo mutation, meaning these patients are the first one to have these mutations, likely when they were embryos. So their parents will be negative for this mutation. And I've seen in my clinical practice, these are the patients who will not have a family history of polyps or cancers. A typical case will be a 20-year-old with rectal bleeding, and you will not suspect any polyposis, and their colonoscopy may show you hundreds and thousands of colonic polyps. So FAP is still rare. It accounts for less than 1% of colorectal cancer, and it affects both genders equally. So APC mutation results in aberrant accumulation of beta-catenin, and it leads to transcriptional activation of Wnt signaling pathway, and it targets genes that control cell growth. And this is important to know here because somatic APC mutations are found in as many as 80% of sporadic colorectal adenomas and cancers. So some of your colorectal cancer patients may undergo a somatic testing done by their oncologist, and that is to understand the natural history, prognosis, and chemotherapeutic targets for those tumors. So a somatic mutation by itself, if it does not translate to a germline mutation, is not FAP. And this is, again, a common referral in my practice. So FAP versus AFAP, what's the difference? So AFAP stands for attenuated FAP. So both of these are same gene mutations, but very different conditions. These patients are managed very differently, and their phenotype is very different as well. So AFAP is here. You can see this is the APC gene, and attenuated FAP is in different codons. So it exists in these codons here next to 3' here from this green area or the small area here. Your genetic counselors or your experts, they can guide you based on which codon of this gene is mutated. They can guide you whether this person will behave like a classic FAP with profuse polyposis versus an attenuated version. And here there is a genotype-phenotype correlation. So where exactly is the mutation can be helpful in guiding you sometimes to see if that person will develop Chirpies, which is the retinal pigmentations we saw. And this is seen in these particular codon regions. How many of these will get, upper GI adenomas? This codon area, they are more likely to get childhood hepatoblastomas, and similarly for thyroid tumors and desmoids. So you can get some idea based on the genotype location, what your patient's phenotype will turn out to be, and manage them accordingly. So again, classic versus attenuated FAP. So in attenuated FAP, you may have 10 to less than 100 colonic adenomas. By definition, 100 or more is known as classic FAP. And then for classic FAPs, we start colonoscopies at much younger age, at 10 to 15. But in attenuated, based on family history, we start at later age. And in classic FAPs, all will end up needing colectomy, sometime in their early to mid-late 20s. But in attenuated FAP, you try to manage them endoscopically. I have several attenuated FAP patients. We just do frequent colonoscopies and try to stay on top of their polyp burden. And these are the patients you want to schedule them not in your routine screening colonoscopy slot. Yeah, if you plan to remove 30, 40 polyps, so it's a longer slot you plan in advance. And many of these you can avoid colectomy if you can control the polyp burden. So timing for colectomy in classic FAP. So these patients, you try to scope them, in their early teen years and see what their polyp burden is. And I work very closely with these patients that instead of having a one fixed date or year of their colectomy, you work with them how emotionally ready they are. Many of these kids are going to college. What stage they are in their life planning. So I work with them, their parents, and try to find a right time when they're ready to lose their colon. But there are certain situations where you have to prioritize surgery. And for example, obvious ones are if they have GI bleed, they are having increasing large polyposis burden, and they have polyps with high-grade dysplasia, or larger adenomas, or if you are unable to adequately survey the colon because of very large colonic thousands of polyp burden. In those patients, you prioritize surgery. If not, if you can survey them, I try to just keep a close eye on their colon and find a good time in their early 20s to have a surgical management plan for them. So extra-colonic manifestations, even after colectomy, unfortunately, these patients are not out of the woods. You deal with some extra-colonic issues like papillary thyroid cancers, epidermal cysts, bone osteomas, desmoid tumors, adrenal gland adenomas, supernumerary teeth, and we talked about chirpies, which are congenital hypertrophy of retinal pigment epithelium. So here are some images. This is a desmoid tumor. I had a patient. These are smooth muscle tumors. They grow like a mass, and they can occupy the entire abdominal cavity. One person actually needed a small bowel transplant. The entire small bowel was transplanted, and he has done extremely well. I think 6 years after transplant, he is running marathons. Here is again an example of these patients with osteomas. So surgical options we talked about. When you scope patients with FAP, or for that matter, any patient with polyposis, consider a good mapping of their rectum to guide your surgeons. So after scoping these individuals, I have a discussion with the surgeons based on my finding, whether these are individuals who need ileal pouch anal anastomosis, where both colon and rectum will be removed. And in these patients, there is risk still there for cancer in their rectal cuff, which is anal transitional zone, or rarely their ileal pouch can also get cancer. So irrespective of the surgery, they need to stay in some kind of surveillance program long term. So for other patients who have high rectal polyp burden, who do not have high rectal polyp burden, you try to do total colectomy with ileorectal anastomosis. As we know that rectal sparing definitely improves their quality of life. So in this surgery, entire colon is removed, but the rectum is retained. So it's a less complicated surgery. It causes less bowel and sexual dysfunction, but these patients have ongoing need for close surveillance, as the remaining rectum is high risk for polyposis and colorectal cancer. And this is a discussion, the field has shifted towards rectal sparing for these patients. We used to have a number of less than 10 adenoma in the past, but now even patients who have a little bit higher number of rectal polyps, if I can work, in their rectum and remove all the polyps, we try to save rectum as much as we can. But I ask for an agreement with my patients that they do promise to have a close surveillance of the rectum afterwards. And this is a favored surgery if I can, compared to ileal pouch anastomosis or ileostomy, as these are young individuals. So surveillance post-colectomy, as we discussed, they need ongoing endoscopic surveillance for rectum and ileal pouch every 6 to 12 months. Occasionally I see some older individuals, they had their colectomy, the rectum was still there, they forgot about it, their teens forgot about it, and they end up with a rectal cancer. There are rare reports of cancer at ileostomy stoma as well, believe it or not. So with the altered surgical anatomy, even if the entire rectum and colon is out, their stoma should get periodic look for super rare events of just end ileostomy cancers as well. So upper GI tract surveillance in these patients. So after their colectomy, the second cause of death in FAP patients is ampullary cancer. So they have increased risk of duodenal ampullary cancers. And we start upper endoscopy age 20 to 25. And then side viewing scope, which is ERCP scope, was used in the past to look at the ampulla. However, we have seen recent data that a clear cap. So here is an example. You can just attach that at the tip of your scope, and I try to tape it real good. And you are able to take a turn and look at the ampulla in these patients. It seems to work 99% of the time really well, just for examination. So I do not do ERCP side viewing scope for just examination for these patients. So if no duodenal adenoma is seen, they should get repeat upper endoscopies every, 4 or 5 years. So fundic in FAP patients, gastric fundic gland polyps. So you will see their stomach will be loaded with many of these polyps. Here is an example for patient with FAP. So this, I always tell my patients that they get really worried about the number of these tiny polyps. But even though it looks scary, these fundic gland polyps, the risk of progression to cancer is a lot lower, than what we are used to seeing in colon polyps. So, however, these can be troublesome if these are large in size, so which is a centimeter or more, or if they have irregular appearance. In that case, they should be biopsied or resected to look for dysplasia. One common cause, a commonly seen situation is low-grade dysplasia. So this is a take-home that low-grade dysplasia is common in fundic gland polyps, and patients should not undergo extensive surveillance or gastrectomy for these low-grade dysplasia in small gastric polyps. However, if you see high-grade dysplasia or gastric cancer, then surgery or now EST should be an option. And the last thing is if you see polyps in the antrum. So if you pay attention, most of the fundic gland polyps in FAP patients are more proximal in fundus, in cardia body. So if you see polyps in the antrum area, those are generally either hyperplastic or adenomas. And the goal should be to clear the antrum, even if those are smaller looking polyps. So I like this table as a nice reference to approach gastric polyps in FAP. So again, as we discussed in the prior slide, if these are fundic gland polyps, if they are smaller in size, or if they have just low-grade dysplasia, you can just survey them back in 3 years. And based on the larger size or increasing pathology, or if they are like gastric adenomas, pyloric gland adenomas, then you consider extensive surveillance as it's listed here. Okay, so we talked about gastric polyps in FAP. So how about duodenal polyps? So modified Spiegelman staging should be used for duodenal polyp scoring, and that includes polyp number, size, histology, and presence of dysplasia. So it's really important if you scope these patients that you are commenting on these numbers. So if you just say multiple duodenal polyps were noted, it doesn't help with Spiegelman staging when I see them in clinic. So, was this number 5 to 20 or more than 20? That is necessary. The same way, size, if you say small to medium polyps, again, that doesn't help. Accurate documentation, like whether the size was less than 5 millimeter, more than 10 millimeter, is extremely helpful. And the rest is based on pathology. So based on these data, you try to calculate a modified Spiegelman staging for these, and based on the stage, you decide their endoscopic surveillance or need for surgery. For stage 4 patients, for example, here, you generally end up having a surgical discussion for these individuals, and patients who are normal, have none of these, they don't need that close EGDs. I bring them back in about 4 years, 3 to 5 years interval. So other surveillance beyond these organs, there is increased risk of papillary thyroid cancer. So you do ultrasound thyroid, sometimes starting in late teens, and repeat every 2 to 5 years. And I work closely with my endocrinology colleagues for these patients. Chemo prevention in FAP. So lots of studies, there is a lot of interest for chemo prevention. Several trials have been conducted with various agents, including solindac, lartinib, celecoxib, eflornithine. Pretty impressive data we have seen with lartinib, but the problem has been long-term use. So even though we see significant reduction in polyp burden in duodenum early on, these patients do not tolerate these medications for long term. So that makes it challenging to use it outside clinical trials or for routine use. The only thing that I have found helpful in my clinical practice, even though not FDA approved, is solindac. It can be used in case by case for patients, for example, post-colectomy, you want to control their rectal polyp burden. It can be helpful. All right, so that was a lot about FAP. So let's switch gears and talk about the second one in adenomatous polyposis syndrome, which is MUTYH associated polyposis, known as MAP. So a case example, again, a real case example, roughly a 35-year-old physician has rectal bleeding. So he has a few months of rectal bleeding. He thought it's hemorrhoids, and he has no family history of colon polyps or cancers. Colonoscopy shows 2 colon masses and several other colonic polyps. CT scan shows, unfortunately, multiple liver mets. His genetic testing is positive for biallelic MUTYH mutations. So 2 mutations in MUTYH gene, and his parents then undergo genetic testing, which shows each parent was positive for single gene for MUTYH, which is monoallelic mutation in them. And unfortunately, this person ended up inheriting one of the mutated gene from each parent, resulting in catastrophic MAP. So for this person, so MAP is due to biallelic mutation in MUTYH. You need 2 gene mutations because it's an autosomal recessive condition. Unlike FAP and various other conditions we will talk about, which are autosomal dominant, just 1 gene mutation or monoallelic can result in their polyposis condition. However, in MAP, being recessive, you need 2. So for this person's parents who had 1 gene positive, that wasn't enough to cause polyposis, and they would have never known they even carry this gene. So, and this can be here, if you just rely on family history, it can be negative in these patients. And MAP patients usually develop 10 to hundreds of colorectal polyps, and then they have increased risk of colorectal cancer, gastric, duodenal, and thyroid cancers. So for these individuals, we do colonoscopy every 1 to 2 years, starting at age 25 to 30. And then we do upper endoscopy and duodenoscopy at 30 to 35 baseline, and thyroid ultrasound as well. Chemo prevention, again, several trials, but nothing proven or FDA approved for routine use in these patients. So close colonoscopy surveillance and early detection is the key. So little bit about monoallelic MUTYH mutation. So I see it very commonly now that we are doing multi-gene panel testing for patients with, various cancers like pancreas cancer, breast cancer, prostate cancer, right? So your other specialists may end up ordering a multi-gene panel for, let's say, for breast cancer, and they may turn out to be positive for one MUTYH gene. It's common because 1 in 2% of general population can be a carrier. Important to note, it does not cause MAP. There is slightly increased risk of colon cancer, but not really enough to alter colonoscopy screening. So I actually, for all practical purposes, you can do average risk screening for those individuals based on their family history. But it is still important to know if someone is a monoallelic carrier of MUTYH, you can test their partner to ensure they are not also monoallelic, and that will increase their risk of having a child with biallelic. There are studies showing that, in certain geographic areas where individuals that they have people partnering with, close family members. So you may have one MUTYH, even though they're monoallelic, they will have more MAP cases with biallelic mutation. So that history can be helpful. So now coming back to the original slide, in interest of time, I'm not going to talk about these rare polyposis genes, but know that I have patients with all of these. These are rare genes that now we see in multi-gene panel testing for patients with colonic polyposis cancers. We are learning more about them. So the lynch will be a different talk in itself, but let's switch gears and talk a little bit about a serrated polyposis syndrome. Not necessarily we have a genetic cause, but we know that serrated polyposis syndrome is one of the most common colonic polyposis syndrome. Irrespective of your GI subspecialty, you likely have some patients with this syndrome. And there are some reports of serrated polyposis occurring in survivors of childhood, young adulthood lymphomas, cancers. I have a couple patients, they had chemo radiation when they were little, in their early teens. And now in their 30s, 40s, you see that they have multiple serrated polyps. So this is a phenomenon also known as therapy-associated polyposis. We are learning about this. So these patients, the exact estimate, depending on the study, is variable. So I don't think we understand that well, but roughly 15 to 30% incidence of colorectal cancer in serrated polyposis syndrome, and no well-defined extra-colonic manifestation consistently, even though we have seen a few studies showing some suggestion, but we need to learn more. Here you can see, these are very subtle looking polyp. This mucus, here, blob here is something, if you clean it, is a serrated polyp. And the WHO criteria that you should be familiar with for serrated polyposis syndrome is if a patient has 5 or more serrated polyps proximal to the rectum, and they are all of size 5 millimeter or more, with at least 2 polyps being a centimeter or more, that person, the first criteria by itself meets SPS criteria. If not, the second one is 20 or more serrated polyps distributed throughout the colon with 5 or more polyps proximal to the rectum, and if these are any size. So if you get 20 of any size and 5 or more are proximal to the rectum. So here you can see that the rectal polyps are also being counted in this SPS criteria, and so these patients should undergo closer surveillance. And this needs a cumulative polyp burden. So the polyps they have had in the prior colonoscopy should be counted as well. And in this definition includes serrated lesions of any kind. So hyperplastic polyp is also a serrated lesion, and sessile serrated lesions are the other kind of serrated lesions. and then traditional serrated adenoma. So all of these combined should be included in the SPS criteria. So the question, should you do genetic testing for SPS? And the short answer is you don't have to do that because we don't know, we don't find anything in most of these patients. So what's my practice? I do case by case. So the reason is no clear defined genes associated with serrated polyposis syndrome. There are rare reports of RNF43 and biallelic MUTYH in less than 2% of SPS patients, meaning 98% of these SPS patients, you test will be negative. So that therefore we do not recommend that for routinely for all SPS. So who do I do? Of course, you take full family history, look for other reasons to do genetic testing. So if they have family history of colorectal cancer, that's easy, you can consider it. Or if they have features of adenomas on top of serrated polyps, then you think that could there be an overlap with other hereditary cancer syndrome in those patients I could consider. And now with genetic testing being affordable and available, some patients may want to consider this and may be willing to pay, $200 out of pocket. With good counseling, you may consider in those individuals if they prefer. So management of SPS, high quality colonoscopy with polypectomy until all polyps 5 millimeter or more are removed. And the follow-up I do based on how fast they are making polyps and what their sizes are. So it can be anywhere from 1 to 3 years. And clearing of all polyps is preferable, but sometimes 1 to 2 millimeters, a couple are remaining, they can be surveyed. And rarely, it's super rare, you can do a surgical referral, but generally in my practice, pretty much, super rare. I'm thinking for a SPS patient who need colectomy, you can do close surveillance and manage these individuals with frequent colonoscopies. So management of family members is important to counsel as well, that there is a risk of increased risk of colorectal cancer in first-degree relatives of SPS. So we recommend colonoscopy for first-degree relatives at either starting age 40 or same age as youngest diagnosis of serrated polyposis. So for example, if I have a 30-year-old, I diagnose them with serrated polyposis syndrome, they meet criteria, and they have no cancers, then I'll ask their siblings starting or first-degree relatives to start colonoscopies at age 30, at the same age. However, if they get colorectal cancer, then you try to start colonoscopy in family in their first-degree relatives 10 years earlier. And for the family members, if the baseline is normal, then repeat every 5 years. And if they have polyps, again, they also get repeat every 1 to 3 years. All right, so back to the original slide. So we talked about adenomatous polyposis syndromes. We talked about serrated polyposis syndromes. And now let's switch gears to hamartomatous polyposis syndromes. So what is a GI hamartomatous polyp? So hamartomas are disorganized growth of normal appearing cells in native tissue and is generally considered benign with rare progression to cancers. So unlike adenomas, these hamartomas are not turning into cancers, but they are more like growing larger in size and causing more mechanical issues for the most part. So sporadic singular GI hamartomatous polyps are not thought to increase the risk of cancer, but removal should be considered. So, rarely if you do a screening colonoscopy, you may find one GI hamartoma. I take good family history in those patients. 0.1, 0.5% I have seen in one study that adult patients have single sporadic colonic hamartomatous polyp. So it's rare, but exists. If they have no further hamartomatous polyps, they have no family history, no symptoms, then you don't have to do genetic testing. or frequent colonoscopy for just a single colon hematoma. Similarly, in children, so solitary juvenile hamartomatous polyp, actually, if our Pete's colleagues are online, they are more familiar with hamartomatous polyps in children than adults we see. So, which is a more common version of polyps that they see, and 70% of polyps seen in pediatric population is actually hamartomas. So here you can see that these polyps, if you scope them, they actually look a little different from what we are used to seeing adenomas. These are lobulated, frond-like appearance. Sometimes, just based on their appearance, you can say like this is a juvenile polyp. These are not typical adenomas or serrated polyps. So juvenile polyposis syndrome, JPS. So juvenile polyposis syndrome, Peutz-Jeghers syndrome, these are like JPS, PJS, they all sound alike, but they are all very different conditions, different gene mutations, different phenotype. So juvenile polyposis syndrome is a rare condition with estimates of 1 in 100,000 individuals. I follow a couple of these in my panel. It's an autosomal dominant condition, and the genes we have known so far are SMAD4 and BMPR1A mutation. Depending on these mutations, patients can behave differently. SMAD4, they can get hereditary hemorrhagic telangiectasias, they can have epistaxis, nosebleed, unexplained anemia. So, and that is not seen in BMPR1A. So these patients can present other patients because of the polyps with anemia, intussusception. Children I've seen, they may have kid with having blood in the stool or a polyp popping out of their anus, a large one, or sometimes amputating as well because of the large size. And colon is the most common site of polyp that these can be found in any part of their GI tract. So when should you suspect juvenile polyposis syndrome? So if your patient has 5 or more juvenile polyp in the colorectum, or 2 or more juvenile polyps in other parts of the GI tract, or any number of juvenile polyp in a person with a known family history of juvenile polyps in a first-degree relative. So lots of criteria, a lot to remember, but an example will be, I saw a patient, he had like 2 juvenile polyps in colorectum and then did not make further in repeat colonoscopies, and then his genetic testing was negative. So here, as we saw that a negative genetic testing doesn't rule out these hamartomatous polyposis syndromes because, 30, 40, 50% of the time, gene testing can be negative. We do not know all the genes that cause these polyposis syndrome. So you still have to use their polyposis clinical criteria to make a clinical diagnosis. And this is very different for example, like Lynch syndrome, right? If the gene testing is negative, for the most part, I can say you do not have Lynch, but I can't say JPS, PJS, FAPs. If the gene testing is negative, that rules out these conditions. So for that particular patient, because he did not make any further polyps in repeats, all he had was 2 juvenile polyps, I took away the diagnosis of juvenile polyposis syndrome. Now he's an early adult, and we can look at you periodically, but you don't need frequent colonoscopy surveillance. So you have to get all the records and use the clinical criteria. All right, so management of juvenile polyposis syndrome. So, they get EGD colonoscopy starting age 12 to 15. And these are the conditions, here you can pay attention that since we start colonoscopies early, so these are the patients I will do genetic testing when they are kids. So if I have a mom or dad with juvenile polyposis, I will start testing their kids, around age 10, so that I can offer them endoscopy, colonoscopy appropriately. For other conditions like Lynch, for that matter, it doesn't cause, we don't do any endoscopies early age. So I may not offer them genetic testing until their kids turn adult. So we generally test when we are about to change their clinical management. So it's a shared decision-making with the parents. So for juvenile polyposis syndrome, there is, unlike Peutz-Jeghers, there is not that high risk of extraintestinal pancreatic cancer risk. So juvenile polyposis is more like GI tract polyposis cancer condition. Fortunately, they don't need a ton of US and MRCPs and all, unlike Peutz-Jeghers, which is the next one we'll talk. Again, no well-defined chemo prevention. Trials are not consistent for long-term routine use agents. Okay, so now back to the slide of Hamartomatous polyposis syndrome. So let's go to the second one, which is Peutz-Jeghers syndrome, known as PJS. So Peutz-Jeghers syndrome is named after two physicians, Dr. Jan Peutz, who was a Dutch internist, and Dr. Harold Jeghers was an American internist. And in 1921, long before we knew about any genes, or we had these fancy scopes, Dr. Peutz published a case report of a 15-year-old boy with skin pigmentation and intussusception. And that is a classic story I see. That these kids, growing up, they had a small bowel obstruction, and for years they may do fine, and then you find out at some point that they actually had Peutz-Jeghers. So small bowel obstruction is something that is a big problem for these patients early on. And this particular case report, this boy also had a family history of 4 other siblings with similar issues. So the prevalence, it's kind of rare. The range is wide for 1 in 8,000 to 1 in 200,000 births. So wide range. Again, this is an autosomal dominant condition, and it's due to germline mutation in STK11 LKB1 gene. As we said, it's only seen in 50 to 80% of families. There could be other genes that we don't know of. So absence of gene does not rule out this condition. It's important to partner with your pathologist for these conditions. They can be very helpful in looking at your polyp tissue and guiding you that this looks like a Peutz-Jeghers polyp, this looks like a juvenile polyposis polyp, based on the proliferation of smooth muscles extending into lamina propria and arborization. So some very characteristic features in the polyp that your pathologist can just help you with clinical diagnosis as well. I find this, here is, these are mucocutaneous pigmentations that is classic of Peutz-Jeghers. I had a patient referral, she was seeing her dermatologist for routine skin check, and the astute dermatologist noted these pigmentations and then referred her for genetic testing, and she was actually positive and was diagnosed with Peutz-Jeghers, even though asymptomatic. So here, the other thing you can see in these patients is they can have these classic small bowel polyps, and so lots of double balloon endoscopies for these patients. And here is again a double balloon image of how these polyps can cause small bowel obstructions. So I do lots of MR enterography for these patients, and important for you to have a discussion with your radiologist. So generally I'll be writing please make sure that patient is given the max amount of oral contrast to insufflate their bowel well. And you also ask the radiologist to document the polyp sizes and location, so that when you plan double balloons, you can work with your colleagues, whether they will go antegrade, retrograde, where are the polyps, we are prepared, is it even endoscopically resectable? Sometimes they have a very thick, we recently had a large one with a really thick vessel. So then I had to ask, I think we are getting surgical resection for that one. So good documentation of location and size is important for planning for the endoscopist and even the surgeon, that if they will do duodenal reconstruction, how far along is the polyp, So you plan the right surgeon for that patient. Okay, so manifestations we talked about, mucocutaneous pigmentation, hamartomatous, polyps, for these are PJS. Most commonly is the small bowel. So unlike, I don't see a ton of large colon polyps, but the small bowel being the narrow lumen, loss of SBOs in these patients. And then, unlike juvenile polyposis syndrome, Peutz-Jeghers have, these unfortunate patients have high risk of breast, stomach, small bowel, pancreas, ovary, cervix, and other cancers. So I work closely with my hereditary cancer clinic colleagues to survey their extra-intestinal organs cancer risk. But with good surveillance, these patients may do really well. I have a person with Peutz-Jeghers. I follow the whole family in their, I believe their late 70s, doing extremely well. I just have to remove their small bowel polyps, but other than that, they haven't had any issues. So with close surveillance, these patients may do really well over long term. We already discussed that, all cases do not have mutations, so clinical criteria is different in those patients. So clinical diagnosis. So how do you make clinical diagnosis for Peutz-Jeghers? So it's 2 or more Peutz-Jeghers hamartomatous polyps of the GI tract. And if they also have mucocutaneous hyperpigmentations, which can be seen with mouth, lips, nose, eyes, genitalia, fingers. And also sometimes patients may say that they had these when they were little, but with age, these may fade out. So having that history can be helpful as well. And if they have any number of Peutz-Jeghers polyps, if they have family history of Peutz-Jeghers in a first-degree relative, that also meets a clinical criteria for Peutz-Jeghers syndrome. All right, so management, so lots of scopes, but generally EGD colon starting in late teens and repeating every 2 to 3 years. We also do capsule endoscopies periodically. And one of the GI polyposis conditions with high risk of pancreas cancer, so MRCPs and EUS alternating starting at age 35. And I work closely for these patients with my advanced colleagues to try to combine their endoscopy, colonoscopy, and endoscopic ultrasound at the same time so that the number of sedations they'll get over time is minimized. So care coordination is important as well. Chemoprevention, so rapamycin, mTOR inhibitor, several studies shown regression of the polyps, but the main issue again becomes long-term use. So case by case, people have used these, in certain cases, but not routinely that is to be used because of safety issues. All right, so coming back to the last hamartomatous polyposis syndrome, which is PTEN hematoma tumor syndrome. So I'm not going to talk a lot about it. It's kind of rare, super, super rare, one of the rarest on that list. And it has a spectrum of Cowden syndrome, Banyan-Riley Rubalcaba syndrome, Lermid-de-Claus disease. So based on long list of criteria, again, that will be shared in a review article. I think it's on the box link shared with you. But ton of criteria that you can use for these patients, and they have, it's actually the non-GI cancers is generally a bigger problem. So breast cancer is the most common cancer for Cowden syndrome. The risk of colorectal cancer is not that high, it's about 10%. So they need to see other specialists for gynecologic, dermatologic breast surveillance. And generally, we do periodic colonoscopies every 5 years or so, starting in their 30s. So this is again a summary from lots of data, lots of numbers I shared with you. So one of our prior fellows wrote this review article. It's a nice summary for you to see that depending on these polyposis syndromes, you can have the different gene, and the germline mutation is found in a certain fraction of these patients, and the colorectal cancer risk varies from 100% in FFP to about 10% in Cowden. So you can triage your patients accordingly and counsel. So this is also, wouldn't read everything, but summary from the article that different societies, like, there is some variability, like there is ACG, there is European Society of GI, NCCN, they have a little bit variability. So I try to discuss all of these with your patient, understand what their needs are, what their values are, how much emphasis they give on procedures versus monitoring. And I may use a range of 1 year or 3 year based on their preferences, how far they live, how hard it is. So all of those should be reviewed, and one table management should not be done with every single individual. Similar extension of that table here, as I said. Okay. So last few slides, when to refer for genetic testing, in your clinical practice. So if patients have 10 or more adenomatous polyps, or two or more Hamartomatous polyps. And if you see a tumor that shows mismatch repair deficiency on the tumor testing for sure. And now NCCN, their last year's guidelines, they say that you should consider genetic testing for all colorectal cancer. So, so it's recommended versus considered. So recommended is, of course, you're less than 50, or if you have a colon cancer with mismatch repair deficiency, but is the field moving towards any colorectal cancer, irrespective of the mismatch repair testing, irrespective of the age or family history, you should consider genetic testing. So the field is moving towards, that direction. Here at UCSF in GI clinic, we are promoting genetic testing for any colon cancer. You're 30-year-old, you're 90-year-old, you have family history or not, because we see that about 10% of these, we do find a genetic mutation, either for colon gene or some non-colonic genes that can impact overall management of these patients. So just ending the talk with genetic malpractice. So, what it is. So failure to make a diagnosis of genetic syndrome, or failure to recommend adequate aggressive cancer surveillance or surgeries when indicated, or at the same time, failure of duty to warn family members or provide a family letter to patient or give them guidance to share info with their family could potentially be considered a genetic malpractice. So what's the future? The future is bright. Just highlighting a vaccine trial for colon cancer prevention for Lynch patients. Here is a link to the trial if you have interest. It's a phase 2b clinical trial with triad5 vaccine in combination with N803, which is an immune enhancer to prevent colon cancer. So what we are doing is, in this multi-center clinical trial, we have 3 tumor antigens. So these are the tumor antigens expressed by the polyp or the cancer. You take those tumor antigens, tie that to an adenoviral vector, and give that with an immune enhancer to activate your body and immunity to make ton of antibodies against these antigens. And so that when when your patient is growing a tumor, a polyp or a tumor, these antibodies can kill them. So very simple concept that is being studied. Our fingers crossed. We already have enrolled several patients, open to more. You can reach out to us. Happy to discuss that. And we are also excited. We recently launched UCSF Lynch Syndrome Center that can be accessed here. Here's a screenshot to offer coordinated care for patients with Lynch syndrome, participation in various trials. And at the same time, we also do endometrial biopsy at the same time as colonoscopy with sedation for care coordination. I think a ton of slides. So with